Welcome, everybody. My name is Dr. Amma Benneh. I work as a consultant hematologist at Korle Bu Teaching Hospital. I'm a senior lecturer at University of Ghana Medical School and the director of Ghana Institute of Clinical Genetics. So today, we are going to look at pregnancy in constrained environments when you're living with chronic myeloid leukemia. My center is in Ghana, and this is the map of Africa, and Ghana is in West Africa. This shows the 16 regions of Ghana. So our center is Department of Hematology and is located at Korle Bu Teaching Hospital, which is the largest tertiary hospital in Ghana. Referrals are received from all over the country, all the 16 regions, as well as countries, neighboring countries such as Sierra Leone, Liberia, Togo, and Ivory Coast. Currently at our center, there are 4 consultant hematologists, 3 specialists, and 8 residents in training. How do we diagnose chronic myeloid leukemia at our center? Well, diagnosis is by morphology and molecular testing. Annually, we see 15 to 20 newly diagnosed cases of CML. Median age at diagnosis, about 40 years. Male to female ratio 1.4 to 1, just like worldwide, I should suppose. And currently, there are about 210 patients on tyrosine kinase inhibitors. Our first line is imatinib, and second line, we have nilotinib, bosutinib, and ponatinib. Now, treatment of malignancies in Ghana is primarily out of pocket. So patients will have to pay their way through treatment. The donation of tyrosine kinase inhibitors, however, has changed the treatment landscape tremendously for people living with chronic myeloid leukemia at our center. Way out of reach in terms of affordability. So with tyrosine kinase inhibitors, quality of life and survival has markedly increased, bringing with it the natural desire to live a normal life and live it to the fullest. Having children in our society is very important, more so than others. Cultural and social pressures are significant, leading to immense pressure to have children, especially if you're a woman. So once you get married, everybody then starts looking at your belly to see whether it's getting bigger. If somebody, a woman has a new partner, there's that pressure to have a child with the spouse. Sometimes women are in marriages and they have only one child and you have pressure to have more. So all these put pressure on a woman in our society to have children. So pregnancy is important. So let's look at pregnancy and living with chronic myeloid leukemia. How do we handle it in an environment where resources are limited? The conversation starts at diagnosis, even before treatment. Patients are encouraged to dialogue freely with us. Education with emphasis on possible outcomes are frankly given. The importance of planning with your physician, knowing the treatment options available and possible decisions that have to be made during pregnancy are discussed. Contraception is emphasized among women living with CML. Despite all the conversations and counseling sessions, pregnancy is okay. It does become a journey between physician and patient to ensure the survival of both mother and baby. Our protocol. So once the woman is pregnant, tyrosine kinase is stopped immediately. We then start monitoring the full blood count on a monthly basis. Conditions to start hydroxyurea, the only treatment option available in our setting is when our total WBC or white blood cell count is 100 times 10 to the power 9 per liter or greater, and the platelet count is 600 times 10 to the power 9 per liter or more. We also look at the clinical condition of the patient. Hydroxyurea is started during second trimester after consent is given by the patient. So even during our counseling sessions, when we're talking about pregnancy, we let them know that if you're pregnant and your total white cell count and platelets exceed what I've just mentioned, you may need to have hydroxyurea and we would need your consent. And so when the woman is pregnant, he has already been informed and we wait for her to make that decision. We also tell them that there should be no breastfeeding if you're on tyrosine kinase. So when you deliver, you will not have tyrosine kinase if you're breastfeeding. So we try to encourage, this is also another difficult area, the natural desire to breastfeed. We've been campaigning for 6 months exclusive breastfeeding with its advantages. So that also becomes a challenge. However, we do tell them. So the challenges will be the cultural and social pressures that remain our biggest challenge. The availability of other treatment options apart from hydroxyurea, such as interferon, and the affordability of hydroxyurea treatment and other treatment options. So if you're pregnant and you're living with chronic myeloid leukemia, and as a physician, these are the challenges that we face. And of course, decisions that the patient will also have to do. Living with chronic myeloid leukemia in pregnancy. Let's look at a journey. This journey was made by 29-year-old Ms. M, who presented in 2015 with a 10-month history of an abdominal mass. Significant findings on examination were anemia and a massive splenomegaly, and on examination, the spleen was 20 cm below the subcostal margin. Diagnosis was made by bone marrow aspirate and a reverse transcriptase PCR, the GeneSpec platform, and the BCR-ABL transcript level at diagnosis was 84%. Full blood counts, initial full blood count at diagnosis, her hemoglobin was 9.4 grams per deciliter, total white cell count was 210 times 10 to the power 9 per liter, and the platelet count was 617 times 10 to the power 9 per liter. Patient was started on imatinib 400 milligrams daily in May 2015, responded well, was in hematological remission, so white cell counts were normal, and for 2 years remain as such. However, after 2 years, she presented to the clinic with a 2-month history of amenorrhea. Urine pregnancy test was suggestive of pregnancy. Other tests were done. Ms. M was pregnant. Imatinib was quickly withheld immediately, and patient was cancelled. She was enrolled in an antenatal clinic. Fortunately, Polybu Teaching Hospital has an obstetrician or a maternity department, and so it was easy to liaise with them and look after her, because this was a high-risk pregnancy. Monthly monitoring of full blood count was done. So this table is showing us full blood counts, the first one, when you reported with a 2-month history of amenorrhea. These were her counts. So once the pregnancy was confirmed, we then started the monthly monitoring. So you see the next month and so. But things don't always work clockwise. And so we realized that she didn't come for an appointment between August and September. So after August, between September and November, she missed an appointment. I realized that at the 7th month, the white cell count had a significant increase, but it was still less than our cutoff. And subsequently, on examination, the spleen was tipped. She, however, had a good delivery, and she had her baby. She, of course, decided unilaterally to breastfeed the child, and so appeared for follow-up 2 months postpartum, and that was her full blood count. She still wanted to breastfeed, and she appeared 4 months postpartum, and this was her white cell count. Fortunately, it hadn't gotten to 100 times 10 to the power 9 per liter. So imatinib was restarted in April 2018 when she had stopped breastfeeding, and counts have been stable since therapy was restarted. She was last seen in May 2023, doing well on imatinib 400 milligrams, and the child is also doing fine. So that's the journey of Miss M. In conclusion, I would say that the burning desire to have children in our part of the world is a reality, and people living with CML are not excluded from that desire at all. There is an urgent need for education and frank conversations at diagnosis, especially in societies where influence of cultural and social pressures are profound and treatment options during pregnancy are limited. The need to be in molecular remission, at least major molecular remission or better, cannot be overemphasized, especially in an environment with limited treatment options during pregnancy. It is a journey that has to be made together by the physician and patient, with collaboration with the obstetrician to achieve a successful outcome. I'd want to acknowledge ICMLF, Cepheid, Max Foundation. Novartis and Max Foundation came together to form the Gleevec International Patient Assistance Program, and that has provided free of charge tyrosine kinase to our center since 2007. We also want to acknowledge other pharmaceutical companies who also produce the other tyrosine kinases, Ariad, Pfizer, Bristol Myers Squibb, and the staff of Department of Hematology, our center, at Kolebu Teaching Hospital, for together as a team, we make lives of our patients a better one.